For those joining us, just wanted to let everyone know we're just waiting a couple minutes for others to join. So we'll start the seminar in a couple of minutes here. We'll be starting in a minute here. Still have lots of people logging on, so stand by for a minute. Welcome all. Let's just give one more minute. I have 7:02 and still have a lot of people logging on. So just stand by for a second here. All right, I have 7:03. Let's go ahead and get started tonight. First, I want to give a hearty welcome to all and thank everyone for joining us tonight. So my name is Alex Polikoff. I'll be moderating tonight's webinar. I'm a member of Mid-Valley Healthcare Advocates, a sponsor of this evening's event. And I wanted to begin by thanking our co-sponsor organizations. So that would be the Corvallis and Albany League of Women Voters, Corvallis Albany chapter of the NAACP, and Healthcare for All Oregon and its Lynn County chapter. So we hope to have a really informative and lively discussion tonight on the possibilities for establishing a system of universal healthcare in Oregon and what that could possibly look like. I'd also like to remind everyone that tonight's presentation is being recorded for posterity and let you know that the link will be available. So for those of your unfortunate friends who were not able to attend, you'll be able to share that link with them. So as for the program tonight, I wanted to let everyone know Representative Travis Nelson, who's one of our panelists, has to leave a little early. So we are going to start with his remarks. Hopefully he'll join us shortly here. He's co-sponsoring legislation in the House related to the universal health care that'll be the subject of tonight's seminar. Next on the program, we are going to have Dr. Bruce Goldberg and Warren George give a presentation on the findings and recommendations of the Legislative Task Force on Universal Health Care. That'll take up the body of the presentation tonight. Then we have staff from Senator Manning's office discuss the legislative path forward. Now, unfortunately, Senator Manning was not able to be present tonight. We knew that was a possibility. For those of you who don't know, the full session of the legislature started yesterday. But Senator Manning did spearhead the legislation that created the task force. And he's also sponsoring related legislation in the current legislative session. So after the speakers give their remarks, we'll have a question and answer period where members of the audience can submit questions by clicking on the Q&A box in your Zoom screen. So if you like, you may direct your question to one or more of our panelists. You don't have to. If you don't direct your question, it'll just be thrown open to the entire panel. You may submit questions at any time during the program. So if something comes up and you don't want to forget what question you had, just go ahead and click on the Q&A box and submit it. You don't have to wait until the Q&A period to submit a question. We'll try to answer as many questions as possible within our time frame, so please be patient. Do we have Rep Nelson with us? I don't see him.
You do have me.
Oh, great. Excellent. So our first speaker is Travis Nelson. He was appointed to the House of Representatives January 2022 and was elected this November to his first full term representing House District 44. So he is proud to join the legislature as the first ever Black LGBTQIA+ member. And more directly related to the subject, he's a registered nurse and has served as a union rep and vice president of the Oregon Nurses Association. So thank you so much for joining us, Representative Nelson, and go ahead.
Thank you so much. I wasn't aware that I should have had prepared remarks. I thought I was going to be part of a bigger panel, but that's okay. So look, everybody, like Alex was saying, I'm Travis Nelson, new state representative, House District 44, registered nurse, longtime single payer activist, Nurses for Single Payer board member. And we've got a great opportunity to take a bigger step towards achieving single payer healthcare in the state of Oregon. I've got a bill, House Bill 2558. Oh wait, no, actually, yeah, 2558. And Senator Manning has a bill as well that will implement the recommendations from the that was meeting doing or how to best proceed in moving towards single payer healthcare here in Oregon. That task force recommended that a governance board be implemented, and that's what the bills that are being put forth by my the plan at this point is to use Senator Manning's bill as the vehicle. The thought process is if we can get Senator Manning's bill through the Senate, where we've got tighter margins, we can get this through the House. It's going to be extremely important for activists to show up at hearings and reach out to all of their legislators, letting them know that they move. It'll be especially important to reach out to your senators. My bill in the House is essentially a placeholder bill in case something goes awry in the Senate. We can pick it up and move with it in the House. I've got the fortune of being vice chair of House Healthcare during my first full long session. So I'm hopeful that if something should go unplanned, this thing moving in the House. To for all of you to stay involved and again, make sure that you're reaching out to your legislators.
Thanks very much, Rep Nelson. We appreciate all your efforts on that. So are you going to be able to, I know you were supposed to leave early. Are you going to be able to stick around for the Q&A session or no?
I can stick around till about 7:30.
Yeah, that'll probably be a little too soon for the Q&A. So
okay.
Anyway, we appreciate you. We appreciate your remarks, and if we happen to get done early and get into the Q&A early, then we'll have you on that panel.
Okay, I'll hang around a little bit longer. I would encourage all of you. It's not crazy lengthy, but to read the report from the task force, I think that'll help you get a much better understanding of where we're going
Thanks, Rep. Nelson. And actually, at the end of this, we'll have, we're going to get that out to everybody, a link for both the task force and also contact information for sponsor organizations. So thanks for bringing that up.
Absolutely. Thank you all for being healthcare activists. I know that by working together, we will pull this across the finish line. So thank you.
Thanks. And being on the healthcare committee is going to be a really useful spot to forward the action. And we appreciate all your efforts on that. So for those of you who we're talking about things you're not necessarily that familiar with, that's what the next part of the program is for. So the task force and that report that Rep. Nelson mentioned is from the legislative task force on universal health care that was created in 2019. So our next speakers are going to be Dr. Bruce Goldberg and Warren George, who were sat on that task force. So Bruce Goldberg chaired the Universal Healthcare Task Force. He's currently a professor at the OHSU PSU School of Public Health and a national consultant on the organization and delivery of healthcare. He was founding director of the Oregon Health Authority, or for those of you who love acronyms, OHA, and has spent the last 40 years in a variety of roles leading healthcare organizations. Warren George is a retired aerospace plant manager and business analyst. He is a researcher and frequent speaker on the design of universal healthcare funding systems, which is a critical aspect of establishing universal healthcare. He was a governor-appointed member of the Oregon Legislative Task Force on Universal Healthcare, and he was selected as the fiscal management and change management representative. So Dr. Goldberg will start us off, and then Warren George will pick it up and give us detail on the findings of the task force. So take it away, Dr. Goldberg.
Great, thanks, Alex. Really appreciate being here tonight. Thanks everybody for joining us. Warren and I are going to tag team this. I'm going to do the first part, and then Warren is going to do the second part. And I'm just going to share my screen and thank all of our sponsors for tonight. We really appreciate your putting on this forum. So I want to talk to you about the task force and the report. The task force was established by Oregon Senate Bill 770 in 2019. And this is the task force, a great group. We had 20 members, 4 legislators, 13 governor appointed members, 2 executive branch members, and 1 from the local government. Really great group to work with. And the context in which we really did our work was this, that our current healthcare system is financially unsustainable. I think we all know that healthcare costs are growing at paces that far exceed general inflation, workers' wages, you name it. It's harmfully complex. Those of us who work in the healthcare system and those of us who get care in the system know how complex it is. And it's socially unjust. Many of us don't get the same care. Right now, the number one cause of personal bankruptcy in our state is healthcare debt. And most of the people who experience healthcare debt are actually insured. So go think about that for a moment. Healthcare in Oregon is inequitably delivered and paid for. Providers of healthcare get paid more to take care of wealthy and well-insured people, and they get paid less to take care of poor and the elderly. And too many Oregonians, because of their race, age, income, geography, insurance, endure vastly different healthcare access and different quality, and unfortunately, different outcomes. So we have a complex and socially unjust system that we really sought to make better through a single payer. We had robust public engagement. We had a consumer advisory committee. We had 7 roundtables with historically underserved communities in our state, rural communities, African-American groups, Latinx community, etc. We had 6 regional community listening sessions, including 1 in Spanish. We had forums with healthcare professionals, doctors, nurses, hospitals and health systems. We talked to groups of large employers, groups of small employers, as well as groups of unions, all of which helped provide input and shape the task force's thinking about the report. So in summary, and I'll go into all of this, we've put together a plan in which all Oregonians are covered. Everyone in the state would be covered by this health plan. There would be a robust universal benefit for everyone that includes behavioral health, dental care, etc. Our plan eliminates deductibles, copays, coinsurance, and any other out-of-pocket costs, the kinds of things that lead to bankruptcy. There would be the same payment system for all providers, eliminating, as I mentioned, that structurally inequitable system where providers get paid more for some groups and less for others. Providers of care would bill one entity. Oregonians would be able to get care from any provider in the state. No longer if you change jobs or changed insurance, would you have to go out and find a new doctor. And then the kicker is that the cost of this new system is slightly less than what our current system would cost us. And we're going to go through some of this. So let me go down some of the key elements sort of one by one in a little bit more detail. So in terms of eligibility and enrollment for the plan, all people who live in Oregon will qualify. Doesn't matter what job you are, doesn't matter your income, your immigration status. If you live in Oregon, you'll qualify for the plan. In terms of affordability, as I indicated, no payment at point of care, no copays or deductibles, no more medical debt. We'll talk about how the plan gets financed, Warren will, in a little bit. In terms of covered benefits, the benefit would be based on what is available now through the Oregon Public Employees Benefit Board. It's a very, very robust healthcare benefit that includes the full spectrum of medical care. It includes drug coverage. It includes dental care. We felt that there should be an enhanced behavioral health benefit that would be part of that to be determined. But this is a very robust health plan and covers everyone's medical needs. In terms of healthcare professionals, any licensed or authorized practitioner in Oregon who provides healthcare services that are covered by the Universal Health Plan is a participating provider. So by definition, if you go see healthcare providers for a Universal Health Plan service, they will by definition be a participating provider. And you can see any participating provider. No longer will you be limited to panels of providers. You'll be able to see anyone. Most importantly, participating providers in the plan will not be allowed to give preferential treatment to anybody who wants to pay out of pocket or to charge more for their care. This creates an equitable system. So if someone wanted to see a participating provider and said, gee, I'll pay you more to get better access, you couldn't do that. There would be no preferential treatment to anybody. And quite frankly, a Universal Health Plan participating provider can only be paid and can only be charged the prevailing rate. The Universal Health Plan will prioritize recruitment of a diverse and representative workforce with sufficient geographic and cultural distribution. In terms of provider reimbursement, the Universal Health Plan will reimburse providers directly. Methods and rates of reimbursement will be regionally based. We know that there are some unique needs of communities around the state. There's different needs in different communities, and methods and rates of reimbursement would be regionally based. There'll be the opportunity to have capitated models or other alternative payment models maybe used to improve outcomes and value. But I think most importantly, this really provides an opportunity for providers as well as for consumers to work in collaboration with the Universal Health Plan about payment methodologies, how care will be reviewed, how we'll assure quality. Right now, I think you may know that if you're a provider of healthcare in this state, you may have 20, 30, 40 different contracts with different insurers and different standards for measuring quality, utilization, and payment. Now there'll be an opportunity to work with one entity and to really have there be a collaborative opportunity to do that. That would be huge. Governance. The plan would be administered by a state single payer entity and governed by a nonprofit public corporation, subject to public records and public meeting laws. In other words, this would be a public corporation with board members appointed by the governor, confirmed by the legislature, and they would operate and they would make decisions transparently and with full view and input from the public. Regional entities, as I mentioned, will advise the plan on how to respond to the unique needs of diverse communities around the state, and there'll be a government-to-government relationship with tribes. There'll be a limited role for private insurance in this new system. Insurers will be able to offer complementary coverage. In other words, they'll be able to offer insurance for benefits that are not offered by the Universal Health Plan. So what are those? There's such things as certain cosmetic procedures, which are generally not covered by health plans, hair transplants, other kinds of cosmetic surgery. There may be some prescription drugs that are not available when there are suitable alternatives. There may be services with some coverage limits, 30, 40 physical therapy visits a year, things like that. And long-term care is not covered by the Universal Health Plan. That's envisioned as being a Universal Health Plan 2.0 issue and really part of a larger conversation. So insurers will be able to offer complementary insurance for that. Insurance companies will be prohibited to offer substitutive or supplementary insurance. In other words, they won't be allowed to provide insurance for that is substitutive of the Universal Health Plan. And the health plan may contract with third parties, including private carriers, for benefit administration. In terms of equity, and this is a huge part of this plan, the health plan removes obstacles to equitable care. And let me go through that. First and foremost, everyone in the state will be covered. No longer will we have an unequitable healthcare system where some people get care and other people don't. Likewise, everyone is going to get the same benefit. It's going to be a good benefit, and everyone will get it. No longer will we have real disparities in benefits where someone to afford health insurance has a $5,000 deductible health plan and someone else has a zero deductible plan. There'll be no cost sharing. And as I mentioned before, we'll eliminate the structural payment issue, whereby providers are paid more to care for the well-insured today, and they're paid less to care for the poor and the elderly. So the Universal Health Plan will remove those structural inequities in our current payment system. Likewise, the contributions to the plan, and we'll get through how we're going to fund this plan, are now going to be based on ability to pay. Currently in our healthcare system, contributions are not based on ability to pay, they're based on premiums. And if you make $1 million and work at a company, you pay the same premium as someone who may make $30,000. So the premium contributions are by definition right now inequitable when you line it up with pay. And the plan will work to address issues that affect health outcomes including such things as housing, education, nutrition, violence, and racism. Obviously, the plan is not responsible for all of that, but will work in partnership with others around the state to try and help address those issues. We had a lot of help in doing this work. We had a lot of national experts. We had a nationally recognized actuarial firm do the financial modeling for us, Optimus. We had revenue estimates from the state's Legislative Revenue Office. And we had a series of nationally known consultants. We had a couple of nationally known professors, Professor Fusey Brown and McCuskey, who helped us with the ERISA issue, and Dr. Chow and Dr. Liu, nationally recognized health economists. Dr. Chow, not just a health economist, a Harvard professor, as well as an actuary who helped us in our design of the plan. So speaking of ERISA, just in brief, for those in the know, this is an issue whereby federal law really prohibits states or others to interfere with employee benefit plans like health insurance and retirement benefits. So it's likely that this plan would see an ERISA challenge. Although our consultants believe that we have worked out a plan that would likely survive an ERISA challenge. Obviously, no guarantee there, but we believe that it would survive a challenge, and that's because the payroll tax, which you'll hear about to help fund this, is levied on all employers, and it's done progressively based on employee wage, number one. It's unrelated to the employer's benefit plan, and it's not contingent on them. And it's set at a level that's not felt to be onerous. It's actually at a level which is less than many employers currently pay for health insurance. Employers would still have an option to offer a self-funded plan should they want to. However, if they do that, they would still have to pay the same as other employers for the state plan. So we believe it's unlikely that an employer would offer a self-funded plan. They might offer some complementary coverage, as I indicated previously. So with that, I'm going to shut off my screen share, and I am going to turn things over to my good friend, Warren.
Thank you, Bruce, and thank you, Alex. Just let me get set up here. And go back a slide here. Whoop. Okay, I'm ready. And I'd like to give a big thanks to our sponsors, again, NAACP, League of Women Voters, and Mid-Valley Healthcare Advocates, and Healthcare for All Oregon. Before I dive into some of the financial impacts, frequently asked question as a member of the task force, how can you talk about money when we're talking about injustice or something like that? So I want to take a moment and appeal directly to those who turn off when we talk about dollars. A few tenths up when the dollars are shown, you might be suffering from a serious condition called swing set syndrome. There's an unfortunate adage in our society that the swing set in the park doesn't get fixed until the right kid gets hurt. We can tell that our kid isn't the right kid when we report the broken swing set. Mayor brings out the financial experts to wring their hands and talk about the budget. We know that someone else's kid is the right kid because the mayor gives a speech about money being no object when safety is concerned. Give me a break. All that I can ask of any of you who might be suffering from swing set syndrome is to be open to the hope that this time the money talk is about enabling solutions rather than explaining why it can't be fixed. Just a second here. Having a technical problem, but the task force plan, the financial plan, was prepared by our actuarial consultant, Optimus, according to the key design elements provided by the task force, most of which Bruce already mentioned. Optimus began by collecting data on Oregon healthcare expenditures for the year 2019, then projecting costs forward to 2026, which was assumed to be the year of implementation. An estimate was made both for the current system without changes and for the universal healthcare plan in the form of a single payer system. Pictures of grandchildren, how does that keep showing up in my presentations? As you can see, the actuarial study estimated that a universal healthcare plan would save about $1 billion in its first year, with the opportunity for savings to increase in subsequent years. Now we will dig a little deeper into that $1 billion in net savings. Optimus estimated that about 8 to 12% of the cost of healthcare could be eliminated by simplifying the administrative billing process for medical service providers, such as doctors, hospitals, clinics, and other practitioners. Light blue area on the top bar of this graph shows the range of that savings estimate. Lesser savings were calculated by Optimus for removal of insurance commissions and marketing, economies of scale, insurance company margins, increased purchasing power for drugs and other supplies, savings from making it easier to detect fraud, waste, and abuse. Important to point out that the task force intentionally planned for no savings to come from reducing the net cost of providers for delivering direct patient care. Task force wanted to assure that providers that their income from, at least from seeing patients directly, would come out even with what it is now. Optimus also estimated the increased demand for care, which would result when there are fewer financial obstacles to seeking care. Reading from bottom up, estimates are shown for the increase in utilization from elimination of cost sharings, such as co-pays and deductibles, increased access to Medicare and Medicaid, improving benefits for everybody to be at the public employee benefit level of coverage, addition of a dental plan, covering those who are currently uninsured. Reason I read from the bottom up is that these bottom 5 on the graph are basic mandatory requirements of any universal care system where everyone gets the same good benefits. Together, these mandatory increases in patient utilization would raise cost by about 5.6%. The task force voted to go beyond that by setting aside 4 to 8% of the total cost in order to improve services for behavioral, regional, including rural and other underserved areas, and primary care, including new programs to train and retain greater diversity among providers. When savings and spending on increased services are added together, the total looks like this. The gray areas represent the uncertain range in reducing provider and administration from 8 to 12%. Total gross savings are projected to be in the range of 11 to 15%, of which the task force recommended to spend about 9% on increased services. This leaves a net savings of somewhere between 2 and 6%. There is an adjustable trade-off between savings and increased services. For instance, savings will get bigger if we accept a lower increase in services. Some task force members disagreed with our actuarial consultant on the administrative cost for Oregon to operate a single payer system. Optimus calculated 6%. Some task force members thought we should set a goal of 4%, which has been achieved in the past for some simplified programs. For the final report, the task force agreed to use the consultant recommendation of 6%, but with the hope that savings can be higher than estimated in the report. Using federal funds for an Oregon universal care system will require federal waivers or congressional enabling legislation in order to use Medicaid, Medicare, and marketplace funds. If Bruce were presenting this slide, he would use his past success at getting federal waivers to express optimism that Oregon Universal Care could proceed with temporary short-term waivers and innovation grants. I approached this slide with my own concerns, made more cautious by the passage of Measure 111 in November. Measure 111, the healthcare as a human right measure, does not distinguish between federal or state obligation for healthcare. Instead, the constitutional amendment places the entire obligation on the state. Therefore, I would argue that it is critically important for Oregon to lock in long-term federal funding through an enforceable agreement. An Oregon single-payer plan, as considered by the task force, cannot function without the federal government perpetually maintaining their healthcare program funding at the current level. Task force membership supports a congressional passage of a super waiver bill such as that introduced into the House by Ro Khanna of California. Initially, the task force considered 3 possible tax alternatives: payroll taxes, income taxes, and sales taxes. Although a good case can be made for sales tax as a revenue source for state health care, the task force members decided that the Oregon voter disdain against a sales tax is so strong that it should not be considered for now. Therefore, the task force considered a payroll and personal income tax funding combination. An example plan using this combination was given to the public at community sessions in June. Based on public concerns and some concerns within the task force itself, task force elected not to recommend any specific plan to the legislature. Additional work is needed to determine how to best design a fair and equitable funding system. The final recommendation to the task force reads as follows. Given the problems with the existing healthcare system identified in public input, given the significant potential of a single payer system, the task force recommends that the 2023 legislature appoint a governance board consistent with Senate Bill 770 of 2019 to complete a full single payer implementation plan for review and consideration by the 2025 legislature. Senate Bill 770, sponsored by Senator James Manning, and the companion bill HR 2558, sponsored by Representative Travis Nelson, would create a governance board to create a comprehensive plan. The exact tasks and makeup of the governance board will be decided by this legislation, which has been introduced. Listed here are some action items recommended in the task force recommendation. In addition to completing an implementation plan, secure additional economic and actuarial analysis to make recommendations regarding revenue, engage federal authorities surrounding the appropriate waivers or congressional action, work out remaining details on payment models and operating rules. I will conclude with a few takeaways from the task force study. The task force found that the advantages of a single payer system are real, and they address the problems identified with the current system. Single payer system can reduce the cost, virtually eliminate complexity by eliminating bills, and address issues of social inequity. An interesting point evidenced in the actuarial study is that the biggest part of the projected savings come from simplification of the billing and payment system, not from the governmentalization of the payment system. This goes against some popular thinking, but it is an argument against public options or partial single payer proposals, which would governmentalize healthcare payments, but without the simplification. Funding is what needs the most work. Federal approvals are a critical first step. Without a way to include federal revenue sources, Oregon's single payer system, as envisioned by the task force, will not happen. This is an all hands on deck moment for the prospect of state-based universal health care. Congressional enabling legislation, as introduced by Representative Khanna, needs to be properly worded and approved. As to an Oregon taxation plan, many of us hoped that the task force would produce a taxation plan to recommend to the legislature. We still don't have one. Taxation is hard to agree on and always has been. We need to give thought to the reasons why the taxation plan has been elusive so far, figure out a way to overcome those obstacles. From my own observation, the voters may be more ready than the political process. The 2019 Elway poll of Oregon voters showed 62% support for a new tax 2 to 3 times the size of Oregon's income tax in order to achieve universal care. It's been harder to get that kind of agreement in government settings where members are appointed to represent politically compartmentalized interests. Members tend to feel obligated to fight boldly for their constituency rather than looking for compromises. We can get past these obstacles, but it might require some new thinking. A concluding paragraph in the executive summary of the final report notes that people have anxiety about big changes, and that anxiety is not necessarily irrational. Given the enormity of the proposed change, the governing board is urged to design a transition plan that builds confidence and reduces risk as it goes along. Getting back to the old adage that the swing set in the park doesn't get fixed until the right kid gets hurt. Welcome to universal care in Oregon, where every kid is the right kid. There are obstacles to achieving universal care, but we can and will overcome them. I particularly want to thank Bruce Goldberg for his excellent leadership of the task force's chair, and point out that you can read the full report at the address given on the slide, or just search on Oregon Joint Task Force on Universal Healthcare final report. Bruce and I will be happy to address questions during the question and answer session later in the program. Thank you.
Great, Warren. Thank you so much. And thank you again for your work on the task force. Those that don't know, Warren was not an initial member. He stepped in when a member resigned. So we're happy to see him join, and especially happy for his contribution and for, as he said, Dr. Goldberg's contribution to that was not an easy job running that task force. And it took years to get that report out. So we all appreciate that. A couple of record keeping things. Thanks. I've already seen questions coming in. There have been a couple people asked about, is captioning or subtitles available? And unfortunately not, but I've been told that you will be able to view captioning when this recording is posted to YouTube. So sorry that that's not available tonight, but if you look at the recording under YouTube, if you missed anything, you'll see caption available then. There's also a question on how many participants we had. We have 152 participants as of now, so that's great. Although it'd be nicer if we had 400 or 500, but 150 is a nice audience, and really appreciate everyone being here for that. So as Warren was winding up talking about next steps, that just feeds right into our next speaker. So again, unfortunately, we didn't have Senator Manning available, but we have his staff available. So Kenzie Seifert is Legislative Director for Senator Manning. She came to the legislature in 2020 after graduate work in Russian and Eurasian studies at the Harvard's Davis Center. She joined Senator Manning's staff in 2021 and is proud to work on behalf of Senate District 7 and the people of Oregon across the whole state. So thanks for being here, Kenzie, and maybe you can talk a little bit more about the path forward and what's happening at Senator Manning's office. Thanks.
Yeah, certainly. Thank you so much for that introduction, Alex. And thank you everyone for being here tonight. Thank you to the co-hosts of the program. So glad to be here with you. I think that I can pretty easily speak for all of us when I say that we're grateful for your enthusiasm and your engagement. I am so sorry that Dr. Goldberg and Warren gave such wonderful presentations, because mine will pale in comparison, but we'll get through it together. So it was recommended that I give a quick overview of the legislative process and how Senate Bill 704 will move through that process. For those of you who haven't seen the bill, I encourage you to take a look at it on the Oregon Legislative Information Service, also known as OLIS. There are some resources on OregonLegislature.gov that can help you navigate that system, because there can be a little bit of a learning curve to it, but it's an incredible resource once you have it down. When you access the bill page, it contains a text of the bill and any amended texts of the bill, any analysis provided by our Legislative Policy and Research Office or Legislative Fiscal Office, testimony that's been submitted, calendar details, all kinds of other fantastic information. And another really excellent thing is that you can subscribe to e-updates on the bill, which will help you track its progress through the legislature this session. Representative Nelson very kindly explained already why we have submitted bills in both the House and the Senate, even though the Senate really thinks it's the House where things tend to go awry. That's just the perspective from the Senate, but in any case, we are so glad to have such an excellent partner in the representative. And so very glad to have his support there. This is going to be a bit of a refresher for some folks, but it's good for understanding the context and really the step-by-step of what needs to happen for Governor Kotek to sign this bill into law. We begin with submitting the concept idea to our legislative counsel, who are the lawyers that help us draft our laws. Once we have that draft back, we submit it to the Secretary of the Senate's office in order for it to be introduced or included in the session on the floor of the Senate. From there, the Senate President's office will assign a bill to a committee, which considers it. And once that bill is in committee, it needs to be scheduled for both public hearings and work sessions. A public hearing is when input or testimony is accepted from Oregonians. And because of the pandemic, we have expanded options for testifying that mean you can participate not only in person or in writing, but also virtually, should that be helpful or necessary for you. I'm really glad that we have these expanded accessibility options. It provides for so much more participation from Oregonians across the state who can't make it to Salem and feel really moved to speak on the bills that come through the legislature. When it comes to public hearings, several may be scheduled depending on whether there are possible amendments that change testimony that comes in. And then once that process ends, the committee chair will schedule work sessions. And the public doesn't participate in work sessions, but may observe as legislators discuss the bill and vote on whether or not to amend it, to send it to another committee for consideration, or to send it to the Senate floor for a vote. The notification of that vote is called the third reading of the bill. And that's the language that you'll see on OLIS on that website. So if you sign up for e-updates and you get an email about Senate Bill 704 being third read, that means that the entire Senate is coming together to vote on whether or not to pass the bill on the Senate floor. Once that bill passes, It heads to the House to be assigned to a House committee where the process repeats itself. There are a couple of exceptions because there always are, particularly when the Joint Committee on Ways and Means is involved. That committee, of course, handles the state's budget. It counts as both a Senate and a House committee. So whatever side has already had it go through a policy committee like Senate Healthcare, instead of it passing through another policy committee, it tends to go straight to the floor for a vote. And then once naturally it passes both chambers, it heads to Governor Kotek's desk. I've had a few questions about the broadness and simplicity of the current text of the bill from those who have read it. I think that Dr. Goldberg and Warren have done a really great job of sort of explaining where that comes from. But I'll add that on our end, in crafting the language, we wanted to be very intentional about sticking closely to the recommendations of the SB 770 Task Force on Universal Healthcare. That is why this next step that we're taking is establishing the governance board. There remains work to be done on key tasks like the funding and tax structure, securing federal waivers, et cetera, and that will be the board's mandate. And it will be shaped obviously by the conversations that we have in committee as the bill moves forward. It's deeply important to Senator Manning to honor the work of the task force. They put in an incredible amount of care and energy into this effort. And the recommendations from that final report are going to remain our brightest guiding light. So I will stop there because I want questions to sort of have plenty of space. But I want to encourage you that our office is open to questions and looking very forward to hearing from you and working with Oregonians around the state to launch universal healthcare here.
Great. Thanks so much, Kenzie. And really thank Senator Manning so much from us for being like an unwavering supporter of universal healthcare. I mean, this would not, I don't think this would have happened at all without his continued support. So now's the time, like Kenzie said, now's the time to have, I was gonna say, all your questions answered. And we've got a lot of questions, a lot of audience. So we'll at least try and get as many of them answered as we can. So please be sure, if you haven't asked already, click on that Q&A box and submit your questions. Panelists, that's talking to you, Kenzie, Warren, and Bruce, if you wouldn't mind unmuting and starting your video, so you'll be available to answer questions here. And I'll start off here. Question number one, many of us are wondering about the Medicare interface with this plan for Oregon. Would we continue to pay for Medicare Part B? Just wondering what we will be paying for with this universal plan. And unless I direct it to someone particularly, and very few of these questions are directed to any particular panelist, then anyone feel free to chime in if you're so moved. So go ahead, panel.
I can address that somewhat, since I notice Bruce temporarily looking at his shoes. If we're going to use Medicare money from the federal government, then the revenue that gets to the federal government, of course, it has to keep flowing to it. So that means that things like Medicare, FICA payroll taxes would continue, and it would mean that premiums would continue. There's actually some fine detail in the background. Part B is optional, but Oregon would need Part B to be mandatory. So it is possible that Oregon would take over the payment of the Part B premiums, but that hasn't been resolved. The key thing is that the money still has to get in there somehow. But there's more than one way to do that. Thanks for the question, and I hope that gives you an idea.
Let me just add a couple of pieces to that. One, Medicare recipients would have an enhanced benefit. Currently Medicare doesn't cover a lot of things that we need for our care. Doesn't cover hearing aids, doesn't cover dental care. So there would be a much better benefit. B, access to care would be greatly improved. We have a problem, as many of you know, with access to care for many of us who are on Medicare, with many offices not taking Medicare recipients. So there'll be an enhanced benefit. And I think, as Warren said, we do, as we costed this out, rely on the Medicare money in terms of financing the plan. But I think this is what also Warren was alluding to in terms of why we didn't come up with an exact financing plan at the end, because I think the task force wanted to make the financing equitable and fair. And that means there are some circumstances like Medicare recipients, and would they be required to pay a Part B premium and also a personal income tax? Would that be something that's fair and equitable? So a lot of details that need to get worked out around Medicare. But I think the real message about that is better access, better care, better benefit for those who are on Medicare.
Great, thanks. Okay, question 2. Will people who are not documented be covered? Also, will people have to enroll in the single payer plan, or is everyone simply covered by virtue of ?
Yeah, I'll take that because Warren went first last time. Yeah, people who are not documented would be covered. And I think that the details of how enrollment in the plan is going to work needs to be worked out by the universal plan when it's established. I think the task force made it really clear that it needs to be simple. And, much like Medicare Part A enrollment, when you turn 65, we get enrolled in Part A. We're looking for a system which would be simple and easy to administer and not complex in any way.
And to add to that, was a goal of the task force to make it so that you could basically enroll at the point of service if you were not already in the system.
Great, thanks. Okay, next question. We're going to rapid fire these to get as many in as we can. Question is, I will be participating in City Day at the Capitol on the 25th. Who would be best to talk to while I'm interacting with legislators and public officials?
I'll go ahead and take that one. I recommend. I'm so thankful for Dr. Goldberg and Warren's expertise on the others, but this sounds like it's in my court. I would take a look at the bill on OLIS and view the chief sponsors and regular sponsors of the bill. Those are the folks who are already on board. They're ready to vote yes on it today. So folks who are not on that list are where you want to go. I'm coming to you from Lebanon. So I'm also a Lynn County resident. That means, Senator Hayden, for us, it means Representative Jamie Kate for me. Folks like that, that's a really good way to determine who you want to go and talk to and have a conversation with. Folks who are on the healthcare committees or have professional backgrounds are also good folks to talk to. So that's how I would craft your plan in terms of who to speak with. But at the same time, if you need a friendly face, absolutely stop by office S209. We'd be happy to see you in the senator's office.
Great, thanks, Kenzie. Okay, next question is a good one. What if the best person or facility to treat a specific health issue is at Stanford Medical Center or any other out-of-state provider or location?
There'll be provisions for that. That will be worked out. If you're out of state and have an accident or get ill, you'll be covered, much like insurance today has provisions to do that. If you're a PEB member today and you get sick out of state, your care gets covered. And if indeed there are services out of state that you can't get in Oregon, and there are compelling reasons to be able to get care out of state at another facility. Those are some of the things that will be able to happen. The details around that obviously have yet to get worked out and would be the work of the single payer board to put into effect.
Great, thanks, Bruce. Next question. What about hearing and vision, like hearing aids, cochlear implants, glasses, contacts, etc.?
Those are actually part of the PEB benefit and would be covered.
And and the next question is along the same lines. Dr. Goldberg said that the recommendation is the benefits for single payer plan would be equivalent to PEB, or Public Employees Benefits Board. Do these benefits include gender affirming care, and are they designed to meet the needs of LGBTQ plus patients?
Yes, we've been asked that a number of times, and we looked into that, and indeed, yes. And let me just point out that the PEB benefit is meant as a general benefit, which was meant to be able to price out a plan with a robust benefit. When the single payer becomes up and we put together an implementation plan, there'll be a need to go line by line in a benefit plan and be able to talk about what's needed and what things that aren't covered that we might want to add. The PEB benefit, I think, provides a great starting point, and indeed it does include gender affirming care.
Great, thanks, Bruce. When considering potential costs due to increased usage of the system, which was considered by the task force, was there any attempt to consider potential savings due to people accessing healthcare before reaching crisis level, as in an early diagnosis, early cancer diagnosis, compared to when it's already advanced?
I think that it's true that those things exist, but they're kind of hard to quantify, and there's not a lot of studies. So I for my part, and maybe Bruce knows something else, I think this is one of the things that hopefully will make the resulting benefits even better than we have put out using a fairly conservative estimates. Thank you.
Yeah, the actuaries considered increased usage due to people who didn't have care being able to get care, and they priced that in as being a cost. They didn't price in the savings that are alluded to, as Warren indicated. That's tough, and hopefully that would, end up being a benefit in the long run.
Thanks. Next question. How much is the plan dependent on the federal government? In other words, does it stand to lose with an unfriendly Congress or administration?
I'll start this one. Almost half of the people in our state get care through the federal government, either Medicare or Medicaid. Covers, in the high 40% of people in our state. And we want those people to be included in the plan, and we want the revenue from that. So obviously it's going to depend on the federal government, whether that's in the form of waivers, whether it's in the form of laws that are passed. We're going to need the help of the federal government. And, when anything is political as this is, laws can be reversed with passing of a different law. Waivers can be changed, etc. I don't think anything's permanent. It would be hard for me to envision where a successful plan in Oregon would be taken from under our feet once it was established. I think getting established is going to be the key. But we're at the mercy of the federal government for this, for sure.
Great. Next question. Will any direct primary care still exist as an option? In other words, will an individual be able to pay personal funds and thus contract for services with a primary care doctor? Or if that provider is a participating provider in one venue, can that provider accept direct payments for services not billed to the state? single payer.
I'll take that unless you want to, Warren.
No, go ahead.
Okay. You can't pay out of pocket for a service that's covered by the plan. If that provider is a participating provider. If there may be a provider, like I would envision, there might be some plastic surgeons who want to do a totally cosmetic care that isn't covered by the plan. They won't be a participating provider. They'll be able to charge whatever they want. And that'll be that. If you have like a primary care doctor who is taking care of people on the plan and providing services covered by the plan, they can accept direct payment for the services that would be covered by the plan itself. I think that gets at the question.
Yeah, something that I might add is there may actually be some providers that, I mean, they basically, why would you pay for what you can get for free? So if you can walk in and not pay anything, why would you, there may be some reasons that I don't see of why someone would want to pay outside the plan. But there are provisions in the plan that no doctor would be able to accept any amount other than what the single payer system would pay for the same service. And since it's already free, there's maybe not a lot of incentive. But I'd be interested in hearing more motives if someone wanted that sort of thing. Thank you.
Yeah, as I think about that question a little bit more, I think there's some nuance around concierge care. And that's probably something that'll need to be worked out by the board and by the plan administrator.
Could you define concierge care for those not familiar with it, Bruce?
I think concierge care is where you pay you pay a fee to a practice, $50, $100 a month. And for that, you get special access. You get same-day appointments. You get different telephone access. You get greater access to a provider.
Okay, thanks. Okay, next question is a good question. What would constitute a resident of Oregon under the plan? For instance, what about someone seriously ill with a pre-existing condition moving from Washington to live with one of their children in Oregon to immediately get benefits? I doubt we who truly live in Oregon want to pay for those who don't pay Oregon taxes. What is to prevent a shortage of health services resulting from a flood of out-of-staters coming here? Who's gonna go for that one?
I'll start.
I'll take it next.
It is an obvious concern. The attitude of the task force in looking at this sort of thing is the main goal is to get care to people. So if 2% of the people maybe shouldn't be getting that care, that's maybe a reasonable price to make sure that the others get it easily. Oregon has looked at this and other states have as well. And, the thing of it is as long as you put something in place to watch whether people from out of state are trying to suddenly come in. I mean, if you monitor that, then there are ways that you can put in place restrictions, like you have to have lived here for a certain period of time or something to get a certain level of care. A kind of a principle of the task force is we don't care who you are or where you come from. The idea is if you need care now, we'll take care of that. And if you're from out of state, the idea maybe is, we get you patched up so you can get back home to get more long-term care. The first goal is to make sure that everybody gets care. But if someone truly is from out of state, then it wasn't decided exactly yet. but the single payer system would actually bill the out-of-state insurance company for reimbursement for someone who actually is from out of state. And similarly, people from Oregon going out of state would basically have the equivalent of an insurance plan that will pay where they go. You have anything to add, Bruce?
Yeah, the one thing I would just add to that is, I've been in this business for a long time, and every time Oregon has expanded coverage in one way or another, this issue always comes up. Are people going to flock to our state? When we had the Oregon Health Plan, when we expanded access to the Oregon Health Plan, recently when we expanded coverage for undocumented children, now when we've expanded coverage to undocumented adults. And I would say that never in any of these circumstances have we seen a flood of people into our state. We're fortunate. We have a state that is fairly generous, and so I don't see where this would be a real issue. It's always brought up as a concern, but it really never becomes a reality.
Yeah, I'd just like to add to that. I really encourage folks not to approach this from a scarcity mindset, or to, think of this change, of this action happening in a vacuum in Oregon. The Joint Semiconductor Committee met for the first time this evening, and they're focused on pulling down, parts of the $280 billion from the federal government to, fund a semiconductor technology building in Oregon. And, so it's not we win if every Oregonian gets care and people who are not Oregonians don't. It's we all win when our communities are healthy and happy and productive.
Great, thanks. Good points. Okay. Next question. I am now on Medicare and TRICARE for life with no premiums. Do I lose that? Do I then pay for personal income tax?
And I think we covered that a little bit before in terms of Medicare. You would have the Medicare benefit plus. So you'd have everything covered by Medicare, and then you would have everything covered by the Universal Health Plan, so that Medicare doesn't cover. So it's sort of a semantic. You would still, you wouldn't lose your Medicare, you'd get a better Medicare. TRICARE is actually something that the task force never really got to how we would handle the TRICARE, the vets benefit. And I think that's something that still needs to get worked out.
And to add to that, there is potential for what does the state do about third-party liability, which could include auto liability care, and some of those things aren't worked out. But the idea is the state would have some ability to go after funds if there's somebody who's already signed up to pay for that. But that is probably really more of the concern of the state. Individuals should have full care without a lot of hassle, no matter what.
Yeah. And I think this just illustrates the importance of the next step. There's a lot of really great questions that are really getting at very specific and detailed situations that the task force didn't really have a chance to get into. Now is the next phase is really to dig into and to answer and put into policy a lot of these questions.
Great, thanks. Next question. Is there still a path forward for a single payer system if the feds don't approve waivers? Or are we 100% dependent on the hope that those waivers will be granted?
I have an answer to that, and I'll actually do a quick share screen here. I made this graph a couple of days ago to kind of show the problem of multi-payers with Medicare paying 81% of the average cost of care, Medicaid paying 69%. These are from Optimus's numbers, and private insurance paying 137% of the cost of care. So, you know, the problem is how do you make it so that the private provider is actually getting better reimbursement or getting same reimbursement for everyone without including the Medicare and Medicaid? You know, I wouldn't say that we would ever give up, but you can see that it's very difficult to get to a unified system if the federal government doesn't play. There are some limited areas, including I think around Grand Junction, Colorado, where providers themselves have tried to pool the money from the different sources. And maybe that works or maybe it doesn't. There's also a possibility of all payer systems. But really the best bet is to get everybody into that single pool at the single cost. That's my answer.
Thanks, Warren. This next question, now maybe this is something for you, Kenzie. How would you deal with the private health insurance lobby regarding this single payer program?
Very good question. We are very much looking forward to working with folks who are ready to reimagine a better system. We're simply in a place where we've all experienced it's not working. The rising costs are untenable, they're unsustainable, and something's got to give. And so it's in everyone's interest to come together on this. I grant that it's a challenge.
Yeah, I think the key to this is going to be you need good allies and you need a strong coalition. There's no doubt that the insurance industry is going to be opposed to this, but you know, the issue is how many people we can get in a coalition of people who are supporting this from a wide cross section across the state. That's going to be the key. The key is going to be that's politics, and politics means lining up a whole lot of supporters and coalitions from a whole variety of interests. And if you can do that successfully, you can win the day.
I would add to that well, insurance companies may not be on our side. Actually, hospitals and other major providers actually have an interest in this. And currently they've been aligned with the insurance companies, but they might see a better way to do things. You know, talking to our own local hospital system, you know, they say we'd really like to get out of the fee for service hamster wheel. If it would completely turn the organization upside down to actually be centered on patient care rather than being worried about making payroll and what kind of billing tricks you have to do to make payroll this month. So there might be some alliances that you might not have considered that would actually favor this kind of program. Thanks.
Great. Okay, next question. Did the task force consider how the new plan would help control costs in the future? And if so, what is the thinking?
Great question. You know, the biggest problem in our healthcare system today is the unsustainable increase in costs and the waste in healthcare. And we need to be able to do something about that. The task force did, as many things, didn't come up with a plan to reduce costs. That's going to actually be the work of the single payer board. And they need to have a strong plan to do that. What we do know is that it's a lot easier to reduce cost and redundancy in the system when there's a single payer, as opposed to when there's 3, 4, 5, 10, 20, 30 different payers with different standards. I mean, one of the biggest ways, as you saw, of reducing cost is reducing the administrative burden. That's across the top. But then when you get down even further, there will be better ways for the plan to reduce costs in collaboration with providers. And I think there's a strong recommendation that this is a real opportunity for providers of care, as well as for the governance of the single payer, to work together to lower costs, to provide the best care, to be able to assure we have increased quality, and to be able to do that at a price we can afford, to be able to not pay for care that doesn't work. And those are going to be difficult issues, but things that the single payer is going to need to deal with. The specifics of which, however, we just didn't have the time to get into.
And I would just add to that about a third of the reason why healthcare costs more in the United States, about double, is because of the cost of prescription drugs, the differential between the United States and other countries. This plan, even with the savings we have, we're really not getting into that. And there is potential there. There's potential in others to go after additional savings. But other than that, I really like Bruce's answer.
Great, thanks. By the way, Travis, if you're still there, please join the panel. I don't know if you're, I see you're on the, it looks like you might still be there. Go ahead and unmute and turn your video on, because we'd love to hear from you on some of these as well. There was a question about gender affirming care, which you addressed, Bruce, but one part of it, this other question asked, was, I think, is pertinent. They said, how will access to such care be provided in rural areas? Which is a great question, because we're already dealing with workforce shortages, which is a big topic in the healthcare committee right now. So how would the single payer program address that, care in rural areas?
I think this is why the task force has recommended that we have these regional entities that would be able to address the unique needs of different parts of the state, rural areas, and other communities. So I think that the single payer would look to these regional entities to help assure that such care could be provided in rural areas. I mean, we know, and then I guess I would just add that, we know today we have shortages of a variety of care in our state. And I think we need to be honest with ourselves and understand that the single payer health plan isn't going to be a solution for absolutely everything. And, particularly things like some of the provider issues, I think that's still going to be a problem. Having said that, certainly by equilibrating payment will make it so that there are areas of our state which currently a lot of providers don't go to because they have high Medicaid and Medicare populations. Now there'll be some incentives for people to practice in those areas. So a lot to get worked out. I guess a long way of saying I don't have a specific answer to how that will happen, but a real important issue.
And I would add that once you get to the single payer model, where more or less the state is contracting with providers, it's possible to view the world instead of let's locate the fire department next to the most expensive houses. The idea is most places have standards that they want, a fire truck within 6 minutes response time or something like that. So it would be possible to actually have a different view of how you place your resources. And in healthcare, there are some trade-offs of, do you put how much, cardiac specialty do you put in Fields, Oregon, versus the ability to transport quickly, transport people for very specialized applications. thanks for the question. It's a really good one, and we got ideas, but they have to be worked out.
Great, thanks. Here's a question just for Kenzie. Have you discussed a potential hearing date in the Senate Healthcare Committee?
I feel so special. At this point, there's not a date in mind, but I will point out that Senator Patterson is the chair of the Senate Health Committee, and she is a co-chief sponsor of the bill. So there will definitely be news on that front in the coming weeks.
Great, thanks. Next question, how will Native Americans be covered? How does this integrate with current health service for those that already have insurance through their tribe?
Native Americans have a constitutional right to health care, and the plan does not contemplate that the services current being provided by tribes would be a part of the plan. So in other words, Native Americans would still be able to get care through their tribal healthcare systems. They would, however, also be able to get care if they wanted to through the single payer.
Great, thanks. Here's a question. Let's see, I'm sure Warren will want to chime in on this one. After meeting with our representative in Eastern Oregon, her concern is taxing the poorer people who have had to carry the brunt of taxation. What is your vision?
Well, I think my general response to that would be, I think the best tax, this is from a book by T.R. Reid called Find Mess on Taxation in the United States. The best taxes are kind of broad-based, low rate taxes rather, and healthcare. There's enough money involved. Everybody's going to have to pay something. And one of the challenges that we run into in the task force is kind of balancing the idea that that we want to move a little ways up the ladder of the highest quintile of earners pay a little bit more, but you actually also have to respect that the highest quintile of earners is already paying for about the bottom 35% of the people in terms of Medicaid and in terms of the half of Medicare that is not funded through premiums and FICA taxes. It's a really hard problem, and I'm kind of disappointed a little bit with some of the feedback from the public sessions that everybody is really looking for somebody else to pay. And I think it's been too long, maybe since we had national leadership that, since John Kennedy talking about ask not what your country can do for you, but what you can do for your country. For me, and I'm a Republican businessman, rural, to me, it's about, we can do something good if we look at this from the point of sacrifice rather than trying to gain an advantage over other people. I'm sorry if that was too much.
Well said.
I'll just add quickly, I would really encourage that representative, and I would encourage folks to think about, the difference between, what influence this would have on take-home pay versus the crippling effects of out-of-pocket medical services. I know that as a college student, I grew up in Lebanon. As a college student, I had an asthma attack at night, and the only way I could get to the hospital was by ambulance. And I called my mom sobbing, asking if I could go to the hospital in the ambulance because I knew how expensive that was. It was terrifying. And the whole trip, I'm so lucky that ambulance was run by a student volunteer service, but the emergency room visit was $400. So I was more terrified of $400 than not being able to breathe in my dorm room. That's the cost we're talking about. It is more than financial. It is emotional. It is mental. It is physical. There are costs in other ways, and that's what we're really talking about here.
Great
Thanks,
And-
thanks
and
for making that
and
point. Yeah,
Again, the unjust nature of our healthcare system, the brunt of personal bankruptcy is shouldered by low-income populations. The brunt of having to pay a high premium is, a much greater portion of take-home pay for low-income individuals than for upper-income individuals. And if you set a tax as a progressive graduated tax, you blunt some of that effect. So people are carrying a pretty heavy burden right now of financing our healthcare system that I think will, quite frankly, be a lot less under this new system.
or having to pay a huge deductible, just trying to keep your premium something manageable.
Well, that's exactly it. And then being
God
afraid
forbid
to
something
use your
terrible
healthcare
happens.
because you have a high deductible.
I do want to point out, it is 8:30. Our program was slated to go from 7 to 8:30, but we got a lot of questions. I will ask if the panelists mind just hanging around for another 10 or 15 to answer a few more. Would that be all right?
I'll stick around as long as they're easy.
Well, I can't guarantee that.
Within,
Is that okay to go a few minutes over here?
I'll stick around for a few more minutes. Yeah, absolutely.
Okay, thank you. Next question, which is we hear a lot of people who now work in doctor's offices will be out of work. I assume they're referring to dealing with insurance claims, administrative stuff. How is this being considered?
so go ahead, Brian. Go ahead.
Bruce. No, you go ahead.
Okay, obviously there's going to be some of the functions of administering a plan like this are going to need to be hired for. So there'll be some transition of some people who currently have those sorts of skills to be able to work in administering the plan. Number two, there'll be a creation of jobs by this. There'll be actually, as we know, there's going to be increased utilization of healthcare under this plan. People who currently aren't covered, people who are underinsured, the costs of which have been covered into this, but all of that actually creates jobs as well. So there'll be somewhat of some shifts in the market. I know, Warren, you have something to add to that?
Yeah, just a little. There certainly is the hope economically that if people, right now we're all paying, $11,000 per person on average across the country. If we could get that down to some lower amount, that actually frees up money that's going into premiums now. That is then becomes disposable income that can create jobs. Whether the speed at which those jobs are created is a question. Many states who have considered this have considered, setting aside some of the same savings for training, funds for training, relocation, or helping somebody to get a job elsewhere, or if they're already early 60s, helping them to retire early. The task force is aware of those things, but we did not. We were kind of aware that we might want to set some money aside, but that's one of the things that the follow-on governing board could provide more detail to.
Great. Okay, here's an interesting one. Will out-of-state employers whose employees are Oregon residents pay the payroll tax?
Don't know that I have the answer to that one.
Don't know the answer. Any speculation, or are we going to say that's just a TBD?
Yeah, I think that's fair. We're certainly aware of the problem, but you have to kind of solve how you deal with that, and we just believe that there's a fair way.
Here's an interesting question. As a public-facing state employee, I cannot take an official stance on this bill? How can I still advocate for this bill when I'm off the clock? Am I still allowed to testify? Maybe this, Kenzie, you could address that?
Yeah, so I'll take this. This sounds to me pretty similar to, you know, as a state employee myself, even though I'm partisan staff, I may not engage in any campaign work or political work when I'm on the clock, because I serve the constituents of Senate District 7. However, if I can still engage in those activities when I am not being paid by the state of Oregon. So if you take your lunch hour, for example, to either call into the hearing and testify, or to write up your testimony to send in electronically, those should be allowed, but you should be able to check with your manager to double check on your ethics guidelines there.
Great, thanks. Okay, next question. Just trying to get through as many as we can here and maybe tie up in about 10 minutes. Regarding the required permanent federal government waiver, has this ever been granted? Couldn't a later CMS and/or Congress revoke such a waiver?
Never been granted. No state's done this. And could it ever be revoked? People can pass laws and revoke anything. So I would say, yeah, that potential exists.
Okay,
Shouldn't stop us from moving forward.
right. Did the task force consider how public health and healthcare could be better integrated?
Important issue like long-term care, that's sort of a universal plan 2.0.
And actually, in the Senate Bill 770 is some wording about integrating with public health. And I personally think it's a great opportunity. We don't have the answers, but the goal is actually to integrate well. And public health is actually a fairly popular model that we, I think, could build on, particularly to cover certain kinds of provider shortages or things like that. We can maybe shore that up with the public health system. So I'm a fan of public health, and I know many other people are. I grew up in Tillamook. We had 2 doctors. If they were both out of town, you went to the county health, and it worked great. Not afraid of it. I would like to see it be part of the solution.
Great. Here's a question. Someone's very concerned about their husband's $15,000 to $20,000 a month chemotherapy being covered. How would it?
Would be a covered benefit, so that would be covered.
Okay, that's a good simple answer to that. And following up on public health, will there be enhancements to public health or a focus on prevention? It appears that universal healthcare is focused on provisions of medical services. For example, they're thinking of their care plan covers cost of a gym membership. So staying healthy instead of requiring a lot of healthcare work. How does the plan address that? Or does it?
I think it's that's one of the plan needs to be based on, and is based, and if you read the legislation, on the fact that you've got to base a plan on prevention and keeping people well. The best cardiac care unit and the best cardiac care bed in our state should be an empty cardiac care unit, where we keep people from actually having to go to the hospital as opposed to going there. So a lot of the details need to be worked out about this, but when you have a single payer and you have all the providers in the state and all of the citizens in the state working towards the same goal of wellness and prevention, you do a whole lot better than when we have a scattered system like today. But I think that the foundation of the plan needs to be prevention.
I would add just a little bit of just a slight bit of controversy to that. Is I think many of us would object to a system where they say you've got to take this pill because you've got a 3% chance of better life expectancy or something if you take this pill. And so the idea of the doctor suddenly having control of your life instead of you having control of your life will be controversial to a few of us. But on the other side, as long as we're using quality metrics that of patient satisfaction, and I would love to buy shoes that I got to pay for by the year because they'd last 20 years. There are, it's hard to get to the point where you get to look at the patient 20 years later and then say that was a good thing that you did, and here's the money for it. Metrics are always hard, but one of the things about this, and particularly if there is a chance for large databases, you get to really have a better chance at seeing what treatments are most effective, and those that, to be honest, there are treatments that are done that have very low effectiveness, and yet they're fairly popular. There would have to be some resolution to that.
Yeah, I'll just weigh in that I do agree with Warren here in terms of, obvious prevention where possible is absolutely important. But at the same time, we have to consider accessibility. There are folks who are chronically ill. There are folks who get cancer who have no control over that. And so, when it comes to that kind of public health prevention work, it will really have to, it'll be important to to consider those factors in terms of just accessibility needs. What's important is that folks have access to healthcare. Folks don't necessarily owe health to their neighbors.
Okay, I'm just going to take a couple more questions, but we're getting to the end anyway here. So just a couple more questions. What are the major concerns or opposition voiced by providers or employers? So I guess maybe just a very quick addressing that from maybe the feedback sessions.
The employers, I think, from our feedback session with the employers, they were probably mostly concerned about how the revenue is collected. And the way that we had preliminarily designed really made it difficult for agricultural farmers. We would have a 7% payroll tax on everything. And there's, testimony given by a cherry grower out of Hood River, pointing out that his margin is less than that. So there'll be no cherries produced in Oregon. So I think there's a lot of concern on the revenue side, but actually employers are some of the hardest hit by anyone. And so you'll find many employers who say, get me out of the healthcare business. So it varies, but there's, I think, a lot of encouragement. Some of the larger corporations have told me they're for it, but they have to wait and see how it goes.
And maybe Bruce, maybe you can address the question on providers. Any feedback from them?
We got feedback across the board from providers. I think, in brief, there's some providers who are concerned about fee setting, and, particularly those providers that have a primarily commercial insurance population are concerned about being paid less. Other providers are very happy that there'll be a single fee because those who take care of Medicaid and Medicare, they would get more. I think one of the big things that most providers were very much in favor of is they're very happy to have less administration and to be able to have time to take care of patients rather than deal with multiple insurance companies, multiple billing schemes, etc.
Great. Well, I really appreciate everybody hanging around. Let's do one more question and then end the night. because I know revenue is a big thing and costs. Have analysts been able to estimate costs or cost savings to an individual person or household?
We had about 20, 30 different scenarios, and there's probably a couple of thousand that you could have based on age, based on the insurance you have, based on your income, based on whether you're well or sick, based on if you're on Medicare or not. I mean, whether you're employed, whether you're unemployed, whether you're a small business. So the short answer to this is we had some, but to do it on an individual level for everybody, no.
I would threaten that I would pull out several hours worth of charts and graphs, but I promise that I will not do that.
Oh, we don't have time for that. Sorry, Warren.
All exit left pursued by a bear, unfortunately.
Great. Well, really appreciate your work. I appreciate the presentation tonight, and also, fine job answering these questions. And we actually got through most of the questions. So if anybody didn't get their question answered, we are going to post links for contacts for our sponsor organizations, and also for the legislators. We're also going to include a link for the task force report. Really encourage people to read that. Actually, Jessica, if you're listening, if you want to just go ahead and post that link to the report, the full task force report in the chat now, that maybe people can just copy and paste that. As well, there'll be a recording of the presentation tonight, so be able to, again, if somebody missed it, you can just plunk them in front of a computer and show them the YouTube. So again, I just really want to thank our speakers, panelists. I want to thank Kenzie and Bruce and Warren and Travis for taking the time. I really want to thank everyone who attended. We had 152 people here, so it just shows that there's a lot of interest. So thank you everyone who attended. And also, once again, I will thank properly our co-hosts. I messed up some of the branches. So the Lynn Benton branch of the NAACP, League of Women Voters of Corvallis, League of Women Voters of Albany, and Healthcare for All Oregon, and Lynn County chapter. And of course, Mid-Valley Healthcare Advocates here in Lynn Benton. So again, thank you so much for the attendees. Thank you again to our great sponsors, and hope you found this worthwhile. We'll be sending an email out to everybody who attended with links and the contact info. So again, thank you, and hope I wish everyone a good health and a very pleasant evening.
Thank you.
Thanks,
Great
everyone.
job, Alex. Thanks, everybody.